Hi everyone, I'm just going to go over some brief slides to set the stage for this week's content. I'm not going to go into any depth on any of the topics, just to let you know how you should approach preparing for next week. So we are talking about genitourinary disorders this week. And the first thing I want you to review is you should know what the current guidelines are for routine screening urinalysis for kids. So that's right in the beginning of the chapter, so make sure you take note of that. Because we are talking about infections of the urinary tract this week, you should probably review the anatomy and physiology of the urinary tract because it is relevant when we talk about urinary tract infections, whether they are lower tract infections or upper urinary tract infections, and especially when we talk about reflux, vesico-ureteral reflux. It's good to sort of just refresh your memory on the anatomy. So, you want to make sure that you are thinking in terms of a problem-focused history for a child that presents with GU disorders. So just make sure you review that in the chapter. What do we need to be thinking about in our physical assessment when a child presents with a genitourinary disorder? And in what situations would we treat the patient ourselves or refer? So there were going to be some topics that we covered this week that we don't tend to manage on our own. We would refer out, but we usually evaluate the patient initially to determine if the presenting complaint is benign in nature, as can sometimes be with some of the complaints such as hematuria, proteinuria. They aren't necessarily pathological. So, we'll go through that. So you want to make sure you have an understanding about that. And then, the understanding of what would be the findings that would indicate that we need to refer out. Just a brief mention about voiding patterns. Again, being mindful of at least touching on everything so that you've heard it once, so that when you review for your board exams, it won't be the first time you've seen some things. In terms of dysfunctional voiding, there's some brief information in the text on that. I think what's most important for us is to make sure that we include all possible etiologies, which can include physical abuse, and then a common type of dysfunctional voiding pattern that we sometimes see in sort of preschool, young school age is frequent urination of sort of a benign nature. And so there's a good link, and I can post the link as well here, which just kind of talks about this is fairly common, usually benign. We would probably do a UA, though, if a child presented with urinary frequency, but when the UA is negative, we usually educate the parents on that this is usually sort of a developmental process, kind of a emotional, has kind of an emotional etiology to it. I used to see it fairly frequently in the office, so I wanted to mention it. I don't think it's in your textbook, so that's why I provided this link for you. But I mention it because I saw it with some frequency in kids. So one of the biggest discussions for this week will be the urinary tract infection. There are three main types, so we want to be able to differentiate between the three, know what the signs and symptoms and diagnostic findings are for each, be able to differentiate that because the treatment is different. So you want to make sure that you review all of those topics well. And what we, generally always talk about when we talk about UTIs is that one of the chief causes of UTIs in kids can be vesico-ureteral reflux. So not every child that has a UTI has this, but when a child has a UTI, we need to think about what is the possible reason that the child had the UTI. I did post a really brief video that's a urologist talking about urinary tract infections. I think it's only about 3 or 4 minutes. And so I think, listening to him and in light of your reading will be sort of a nice perspective. He talks about, the typical presentation of UTIs and how constipation is also a leading cause. But when a young child presents with a UTI, especially a febrile UTI, you do really need to think about, is there an anatomical problem or a functional problem that could be causing this? So we're going to talk about that more in class, and your activities will help you to focus in on that. So we do treat VUR. There is some treatment for this, depending on the level of severity. And your textbook gives you some guidelines on that. Then the other disorder we're covering this week is hematuria. Hematuria can be gross hematuria, bloody urine, or microscopic. There's sort of a large number of differentials that we need to think about when a patient presents with hematuria. But, the diagnosis is based on the number of red cells per high power field. So you want to focus on what your textbook discusses in terms of what kind of history you need to ask, what needs to be looked at on the physical exam, whether the patient looks well or has any sort of concerning findings on physical exam. Remember that blood pressure is an important diagnostic measure that we use when we're evaluating kidney problems. So in children old enough to obtain a blood pressure, you should obtain a blood pressure when you're evaluating a child with, symptoms suggestive of a renal disease. So we'll discuss hematuria, and we're also going to be discussing proteinuria. Proteinuria, as I said, both hematuria and proteinuria can be benign depending on the etiology. There's a range of causes. It's not common. And again, because we don't routinely do urine screenings anymore, we don't pick up some of the rare instances of intermittent hematuria, proteinuria. So in most cases, the child isn't going to present with proteinuria, but they may present with clinical findings in which we do a urinalysis to evaluate them, and we find hematuria or proteinuria. If it's gross hematuria, often the child will come in with a history of bloody urine. Obviously, that's more clear. But proteinuria is not something that we would know about. What would be most likely is the child would come in with some evidence of fluid retention and edema. And so this sort of takes us to the next topic for this week, which is nephrotic syndrome. You may have talked about this in your pre-licensure pediatrics. So nephrotic syndrome is an abnormal permeability of the glomerular filtration system, whereby there's excessive excretion of protein. And so the urine is very, very high protein, which causes the blood to become low in protein and hypoalbuminemic, which leads to fluid leaving the vascular space and third spacing. And so you have a very edematous patient. We will talk about the idiopathic minimal change nephrotic syndrome. There are other types of nephrotic syndrome. Some kids can develop nephrotic syndrome secondarily to some other disorders like HSP, which we will talk about this semester. But for this week, we're really going to focus on the idiopathic minimal change nephrotic syndrome. And I have seen a child did present to me in primary care in my office with nephrotic syndrome. So we'll talk a little bit about how to recognize that, what the workup should be, and how to manage that, because it is sort of chronic with relapses and remissions. We'll also talk about glomerulonephritis, the classic form, which is post-streptococcal. So how does this child present? So you want to make sure that you would be able to recognize this you would recognize signs or symptoms that would be would make you think about this possibility as a diagnosis. Physical assessment, obviously blood pressure, urinalysis, physical exam, and depending on the severity, because kids with acute post-streptococcal glomerulonephritis can be quite sick and actually go into acute renal failure. If they're stable, you can consult with a nephrologist over the phone and perhaps treat them outpatient. But as a rule, they will have some blood pressure issues and often will require hospitalization. So it does depend on the severity. So we will talk about that. This will be one of those situations where we'll need to think about what is the clinical presentation that we could comfortably treat outpatient, and what what would be the criteria by which the child would need to be referred in. And then lastly, we're going to touch on some common conditions that we've mentioned probably already in health assessment, maybe even in PC1, but we're just going to talk briefly about them in this course, because we're focusing more on what the management is of these problems in primary care. And obviously, we aren't going to treat, hypospadias, we're going to refer, but again, making sure that we understand, to examine our newborn patients and make sure that we know that the urinary meatus is in the middle of the glands, making sure that we're evaluating for that, and if not, referring on, making sure that we assessing for testicular dissension into the scrotal sac and monitoring that, and referring if they aren't present. Again, I think you've probably heard about hydrocele before, what that would look like on physical exam, and what our role is in primary care in monitoring that problem. Phimosis and paraphimosis, which is tight foreskin, and paraphimosis is when a tight foreskin is forcibly retracted and then forms a tight elastic band around the glands, which can actually be a surgical emergency because it can cut off the blood supply to the glands of the penis. So we'll talk about that, when to recognize that, how to recognize it. Again, that would need to be referred to a surgeon. Balanitis, which is an infection of the foreskin. It's seen not uncommonly in pediatrics in uncircumcised males. And then another fairly common, physical variation in young girls is labial adhesions that we sometimes see in our infant patients and toddler patients. So I've posted the pages where the page where that is, because it's in a different chapter. It's a really short section on labial adhesions. And also I want to make sure that we cover management of hydronephrosis in newborns, because it's not uncommon that a baby on prenatal ultrasound will be diagnosed with hydronephrosis. The measurements of the kidneys on prenatal ultrasound is outside of what's considered the normal range. And so generally those kids will require a postnatal ultrasound at some point. And so that falls under the realm of our responsibility as primary care providers to make sure that that follow-up ultrasound takes place. And if in fact, because many times the hydronephrosis will resolve after birth, it's maybe just something that was an in utero phenomenon. But if a child, continues to have hydronephrosis postnatally, they will also be referred and followed by the specialist. But it is something that sometimes comes across in the newborn chart, and we just need to make sure that we know how to follow that up. So I just wanted to give you a quick overview of this week. You can look at the learning objectives and the reading. There are some resources there. Additional resources which can be supplementary, not required, but even in your burns chapter, it does refer to the clinical practice guideline that I posted for urinary tract infections. So I know I've said that most of the time what's in the clinical practice guideline is in the textbook, but actually in this chapter, in burns, it actually refers you to the guideline for further information. So the guideline is posted for you. And then I also posted the chapters from Adam and Foy on the complaints of hematuria, proteinuria, dysuria, just so if you want to read the content from the perspective of the symptom and not the diagnosis. You can do it that way. Those aren't required. They're additional resources for you. And learning activities for the week will be posted, and we will, hopefully be able to do some cases in class next week. So that's it. Good luck reading.